Yeah, there we go.
Let us know about that. So I wondered if it would be really useful today. I'd really like it if you could just talk me through the whole induction process, because so many of our so just about every single family that I support as a doula, like, is offered an induction of some kind, and often at their 20-week appointment they'll come back to me and say, oh, you know, I was asked if I want to book in a stretch and sweep for 38 weeks or whatever, and I'm just like, why are you even talking about stretch and sweeps at 20 weeks and all that kind of stuff? And then I've seen recently just in the last week, I think new research has come out, an article has come out about induction and how actually it hasn't reduced the number of stillbirths. So I don't know if you've seen that article yet or not.
Yeah. But no, I mean, as far as I know, it hasn't made a meaningful difference. But no, I haven't seen that. That'd be useful to see. But yeah, okay. So I think, I mean, underlying all of this is wanting a level of measuring and controlling around birth, which, depending on your beliefs about birth, just doesn't fit how it works. I was watching an interview that my cousin sent me with a midwife in Australia who works in an Indigenous community in the far north. And he talked about when he went to his training, he got really frustrated the first year because no one would tell him anything precisely. So he wanted measurements, and he wanted graphs, and he wanted, how long does it take someone to dilate? And he found it really frustrating that he wasn't getting answers to that in his degree. And then it suddenly dawned on him that wasn't how it worked. And he had a kind of epiphany of and I was thinking, I know a lot of doctors who have not had that epiphany. And there is the assumption that if we control something, then we can eliminate the risks from it. And that isn't the reality. That isn't what any of the studies tell us, actually. We can try and control something, and it may improve some stats, but it may create some other difficulties. So yeah, the blitheness with which we have inserted induction into so many people's pregnancy journeys is not founded. So basically it's offered for so many things now, some of which there's more grounds than others. So, if someone's got proper preeclampsia and they're just not going to get well until the baby's out, and there's the placenta potentially not working to its optimal capacity, and that might mean that both mother and baby are really going to have risks to their life if the preeclampsia continues. That's probably a really good argument for induction. I'm not sure of many others that are that good, but it comes up for so many things now that even someone who's the absolute lowest of the low risks gets the talk about induction after a certain date. So it tends to be offered, well, the NICE guideline offers it for between 41 to 42 weeks. And already, considering that the NICE guideline also acknowledges that term pregnancy lasts 37 to 42 weeks, you're already intervening in something that potentially is still going just fine. But then, of course, if you're talking about induction for long pregnancies, then we don't know how long any individual woman's pregnancy is meant to go. So that's a population model. And we know, for example, it might be slightly different for women of different ethnicities, but we're not sure about that really. But in terms of each individual woman, I think something that people should always take into account is their family history of when their mothers and their sisters and their aunts and their grannies birthed. And certainly when they last birthed, if they haven't had birth that's been interfered with in terms of bringing on that labour. Because that might give them a more meaningful idea of when their baby might be due and when might be much longer than normal for their baby to stay in. And actually there was a big retrospective study recently now, I think it was Scandinavian, that looked at thousands and thousands of predicted due dates and actual birth dates. And one of the things it noted, which I don't think even many midwives have heard about, in terms of the due date that we use the first scan to predict, that date appeared to only be as meaningful as the due date that a woman comes up with when she calculates her due date using her period. One did not seem to be better than the other. So in terms of when a baby's likely to come, this study said either of those dates, stuck in the middle of a 2-week period, probably gave a 2-week window when a baby was likely to turn up. So that's not very precise. So the 40, I know I'm telling you stuff you already know, Mel. I'm just doing my normal flow of whatever. So the 40-week date is really not something that we can be using for precise calculations. So when NICE says for just long pregnancies, offer induction between 41 and 42 weeks, that's often then influenced because it actually says allowing for woman's individual situation and the local circumstances. And the local circumstances could be anything from how busy things are to how good the staffing is, to what the local trust have decided is their own policy. So I know there was a point where one trust moved to offering induction at 41 weeks, term plus 7, from it having been term plus 12, because they had a really large Asian population in their catchment. And there does appear to be some evidence that the average Asian woman's pregnancy length is shorter than the average white person's pregnancy length. So they felt like the best thing they could do was just bring it forward, their induction date, to term plus 7, but for everybody. So they weren't even individualizing it to those different ethnic groups. They were just going, well, since most of the people we look after are Asian, therefore everybody can have this. And I guess this wouldn't be such a big deal if women didn't get the impression that this was a vital thing to do, that they were putting their baby's life at risk if they didn't, you know, that the baby has to be out by a certain point and another day might be too much, or another 2 days and that might be too much. And if you go back to that 2-week window, we just don't have the grounds for putting that kind of pressure on in terms of another day, another 2 days, even another week. There was another study that came out a few years ago that concluded that for a woman who has previously birthed a normal well baby post-term, as in 42 weeks or longer, there is no, there's no apparent risk to her doing so again in the future. So that is acknowledging that for some women, long pregnancies are normal. Unfortunately, because of induction being offered for long pregnancies, we're going to have a lot of women who never find that out. They never find out that their babies on average might come at 42 plus 3 days because they've accepted induction at 41 weeks. So we're also losing our information base on this as well. And there's so many other variables. You know, we know that the first pregnancy on average, again on population, seems to last on average 40 weeks and 5 days. So you've got a load of women who've passed their 40-week date thinking that 40-week date is meaningful enough that now their baby's late, when actually the average figure for first-time birthers is they birth on average at 40 plus 5. So 40 probably isn't meaningful at all. Yeah, and I just think if we were all really honest and explained and acknowledged how flexible this idea of pregnancy length actually is in terms of what the evidence says, we'd also have to back off from a lot of the pressure we're putting on women to pretend otherwise, as we're doing.
Yeah.
Anyway, and it's go on.
No, I was going to just say, like, that is it's so useful and reassuring to hear you say that, because, and frustrating,
yeah,
or, you know, because I mean, it's not taking the individual into account. It's not taking that person into account. So you talked about that, you know, the study where at the trust where there was a large Asian population. So, you know, based on the observations of the length of term pregnancy in the average Asian population, it's 40 plus 5. So they're just going to do, you said for everybody, like it doesn't matter what your ethnicity is, they're just going to do it at 40 plus 5. That's infuriating. I mean, the trust that I am closest to, you know, from a geographical perspective, they start talking about induction at, you know, they try and book in inductions at 40 weeks. And then when, so that's not even within the guidelines.
No.
So, and then the clients that do say, okay, yes, we will, you know, we're going to book the induction process. Then if the hospital phones and says, actually, we're fully booked, can you go to another hospital, or, you know, we're going to push it back because of whatever, you know, whatever's going on in the hospital, then that makes them really anxious because they're thinking, well, you've told me I need to have an induction. And if I don't have the induction, then something's going to happen to my baby. And so the anxiety and the stress that it causes.
Yeah. And we've set ourselves up for that, you know, because we have created that anxiety. And I see it on the ward as well, where we've asked someone to come in for an induction, and then we've got a really busy 24 hours. And we just make them sit there in their room wondering, you know, wasn't their baby needing to come out, and why are they not anyone's priority? And actually that's completely, and I really find the word iatrogenic useful. I didn't come across it until my 3rd year of study, but an iatrogenic problem is one that we have created. So for example, sometimes when we induce people, if we haven't actually got the dates right, we can iatrogenically create a preterm baby who wouldn't have come out of their own accord, but we've kicked them out and now they're preterm, and there's a whole set of issues to do with that. That was actually for a little while, I think, one of the risks of obstetric cholestasis was that you would have a preterm baby, not because having OC caused you to have preterm labor, but because we were offering induction and sometimes getting that wrong, and actually enough for it to be statistically noticeable that we were having preterm babies to women with OC. Anyway, this wasn't exactly what you asked me, so I'll go back to where we were. So the process of induction, and this is something that, again, the women who look into this tend to be very informed. The women who just hear it as a normal thing that happens tend to turn up with sometimes really unrealistic expectations of what the process is going to involve and how quickly it will happen. So the first step is usually a sweep. And as you say, I think the guideline is now to offer the first sweep at 40 weeks for women who've birthed before. So, and also there's a perception of that's not part of the induction process, but since it is a step to try and get the baby to come out because we want it to, it's got to be considered part of the induction process, because otherwise we'd just be waiting for the baby to come out when it wants to. And again, that's something else that if we've got a 37 to 42 definition of weeks of normal pregnancy length, that doesn't mean that every individual baby is ready to come out as soon as 37 weeks is arrived at. And what it may mean is that your baby was going to come at 39 weeks, but we've now got it to come at 37 weeks. And maybe those 2 weeks there weren't vital, but maybe they were going to make that baby a bit more prepared for the world. We don't actually know, and I think this is really interesting. We don't actually know exactly what starts labor. There's different theories. We don't know why a baby is ready at a certain point to start off its own labor and a week before it wasn't. And again, I think the fact that we don't know that stuff means that the fact that we're blithely deciding it for ourselves is a bit cavalier, really. One of the theories about what might start labor is there might be a hormone that babies' lungs give off once they're complete that is part of initiating labor. That's one of the theories. Suggesting that a baby who is not going into labor of its own accord might not be done with its lung development, because it is one of the last things that happens. And I'm just, this is not evidence-based at all, but, you know, you think of how many kids have trouble with asthma these days. And I think I'd want, you know, a baby to have those extra 2 weeks just in case there was something that was going to go on with their lungs that would make them more resilient to, you know, the world we're bringing them into, which isn't that great for lungs at the moment, depending on where you live. Funnily enough, I wasn't actually even thinking of COVID then, I was thinking of pollution, but that too. So yeah, we talk as if soon as you've passed that magic 37, you know, week marker, And remember, like our 40-week date anyway is this movable feast. So is 37. Is it 37? Is it 35? Is it 38? We don't know. So yeah, as soon as people pass that, they kind of feel as if it's fine for their baby to come. And obviously what we're going on is large population studies that say most of the time it is. But again, we've got to always think about the individualized reality for that mother and baby. So a sweep tends to be the first thing offered. Now, as far as I know, last time I looked, the evidence is that a sweep is only really likely to bring labor forward by about 3 days if it works. So there's quite a strong argument for not doing so, because if your labor is going to come in about 3 days anyway, you probably don't need a sweep. It adds infection risk. It's possible that the person doing the sweep might accidentally break the waters, and that adds a whole other cascade of interventions associated with that, which I guess we'll come back to in a bit once we get to that stage. And it's possible that a sweep may distress a baby in some way. That's pretty rare, but it's one of the things we're supposed to say when we offer a sweep. And again, that could mean a whole set of events then cascade on from that one thing that seems quite low-key. Obviously, also, most people don't find a sweep particularly comfortable. And like all of this stuff that's involved in physical intervention, there are a lot of women who've had abuse or assault issues in the past that this is going to be really difficult for on one level or another, even if actually they've got moved on from it in many ways, but it's associating their birth, which should be something really positive, and the processes leading up to their birth, with something that's been really negative in their past. So, and if what's going on, because obviously that's not something that all women will disclose, or they will disclose to everybody involved in their care. So potentially there's pressure being put onto a woman who is trying to protect herself from something that has very negative associations with her, but she's being told that she needs to think about her baby and she needs to do this for her baby. And that is really not an appropriate conflict to set up, because the only way we look after babies is by looking after the women that are carrying them. So that sweep may or may not do anything. And when I talk women through induction, I say, you know, it's always possible that you'll be really lucky, and one of the early stages will mean that your body goes, oh, all right then, and cracks on. And the earlier that happens in the process, the less interventions you're going to be offered along the line, and the less, you know, kind of checks and monitoring things may come into play. Because, for example, if your body did respond to a sweep, then unless there was some good argument not to, no one would be arguing with someone having a pool birth then. But if you go further down the abduction process line, that's going to be considered not a safe option. So one of the things that I think it's always good to say is you can stop at any point. So you could say, well, looking at the pros and cons, maybe I have some reasons that I might like to consider starting this labour off earlier than it's going to start itself off. So I'm willing to have a sweep, and maybe I'm willing to have the next stage of the ProPES insert, which I'll come on to in a minute, but that's as far as I want to go. And if my body doesn't respond to any of that, I'm going home again. And I really, really think like that should be more out there in the discussion, because it's really hard to get health professionals very used to doing the whole induction process in the hospital to acknowledge that a woman can opt out at any point. And actually, once you get to breaking your waters, you're kind of stepping interventions up quite drastically. And if you are thinking of opting out, you probably want to do it before that. You can always still go home, because hospital is not a prison. But once your waters have gone, there are other things that come into play. So being really clear about these are the steps, and up to potentially that step, you could always just accept a certain number of events and then say you're done if nothing else is happening in terms of your body looking like it's going to come and join in with the plan.
So I've got a question. Well, two, well, I don't know if they're questions. So I don't know of any person who has been told that a sweep could potentially be distressing for the baby. I'm not aware, would a midwife do, or a healthcare professional do checks on the baby before and after the sweep, or how, you know?
Yeah, so we do a full antenatal check beforehand, just the kind of routine stuff that goes on in an antenatal check. But it's the same as vaginal examinations in that we're supposed to listen into the fetal heart beforehand, and we're supposed to listen into the fetal heart afterwards. And we don't know, I mean, distressing a baby, it's not that useful a phrase. And in fact, I shouldn't really use it, because I know there was actually at some point advice from somewhere, I don't know, RCM somewhere, that said we shouldn't use the term fetal distress anymore, because it's an emotive word and we don't actually know what a baby's thinking or feeling. How do we know? We couldn't know. So we should be very precise about what we're actually saying. So when someone says, oh, you know, I had a section because of fetal distress, it's probable they had a section because the baby's heart rate went up and stayed up, or the baby's heart rate went down and stayed down. That's the technical thing that we've observed happening, but we do tend to call it fetal distress. And actually that is like quite an emotive phrase, isn't it? Because that makes it sound like your baby's feeling really awful and, you know, needs an emergency section. Whereas actually, we don't know what the baby's feeling. But this might be an indicator that it's under some stress, either of those things. So yes, to be more precise, it's possible that a baby will respond to an internal examination, like a vaginal examination or a sweep, in some way that suggests it needs to come out quickly. But we don't exactly know why. And we can't even, you couldn't even really hypothesize. I mean, even if that happens, and then once the baby comes out, sometimes it might be something to do with their position. But yeah, we don't always know what that might be. But yeah, so it's really rare that you get a baby's heartbeat that became tachycardic and raised, or became bradycardic, lowered, and didn't recover. But if that happened as a result of something we've done, then we'd need to respond to it as an emergency.
Okay, that's really useful to know. I mean, I wasn't aware of that, so that's really useful.
There's also the possible accidentalness of breaking the waters, because that's another thing where you can create that heartbeat issue potentially, because a baby that is in a comfortable position with the cushion of waters in front of its head might not end up in the same comfortable position once those waters go. So you can again when we do the artificial rupture of membranes in the hospital, we're always meant to listen in beforehand and listen in for a good stretch afterwards to see, does this still sound like a baby that's not under any stress as a result of what we've done? And obviously there's a whole list of associated risks with rupturing the waters, because usually what happens, like the head is the biggest and heaviest bit of the baby, or the heaviest bit of the baby in terms of weight, so it should come down before anything else does. But it's always possible that the cord could come down ahead of the head, when there's suddenly a readjustment to the waters going. So that's something that could, and then again, like it's rare to have that sort of knock-on effect just from a sweep, but it's not too rare from an artificial rupture of membranes. It's one of the risks we're supposed to mention to women that can happen. So if it's an accidental rupture of membranes, that risk is still there, really. Shall I go back to the steps?
So the other thing I wanted to just comment on was how difficult it is. So when I've supported families who have chosen to have the induction process, when they've said, oh, I'd like to just have the ProPES, and then if, you know, labor starts, then go home and labor at home and then come back, and they're told no, that they can't do that. And you're saying that they can stop the induction process at any point. What is the reason that healthcare professionals in a hospital environment, well, obviously that's where the induction process happens, why are they so keen to keep the birthing person in the system and on the process?
I think most of them will say, well, you're here for a reason, and that reason hasn't gone away. So again, because hospital professionals are very comfortable with induction, they do lots of them every day. To them, it's just one way to have your baby. Why wouldn't you? They've often got a very different agenda for this person's birth than the person has themselves. So induction is not a big deal to hospital staff. It can be a really big deal to somebody birthing. So already you've got a disparate, I guess, what's influencing people on both sides of the equation. But yeah, usually, I mean, you know, I was in this situation once with someone with twins, and she hadn't planned to accept induction, but actually her partner worked away, and it was their first babies. So that for her eventually became a reason that she wanted to get going with labour. But it was a very difficult decision for her. And she, as far as I can recall, she had a sweep that didn't get her anywhere. She then accepted the next step, which was to go into the hospital and have a ProPress insert for 24 hours. And the two things that we use to try and start labour off, I'm using brand names, but they're both prostaglandins. So prostaglandins are what our body produces naturally to soften and ripen the cervix and encourage it to, the cervix starts out in tube length, and it has to fully efface, it has to go all the way back till there's no tube left anymore, and thin as it does that, and then start to open. So we kind of think of the cervix as something that's like that, and then it starts to open, but actually it's got a whole process that it does before it starts to dilate. It softens and it effaces, it draws back and goes from being a tube of several centimeters long to just not that bit not being there because it's been absorbed and drawn back. So so that's what we hope will happen when we put prostaglandins into the vagina to sit near the cervix and encourage it to do that. And obviously we're creating artificial prostaglandins to do that. The body has its own version. So when someone's had that ProPress insert sited, then they can be mobile, they can walk around, they can use the loo, they can have a shower, and most of the time it stays in, sometimes it falls out, most of the time it stays in. And usually, unless it looks like someone's going into labour, we wouldn't reassess them again for 24 hours. Because we don't really expect that too much is going to happen in that time unless they're about to labour anyway. So all the way along, if at any point someone looks like they're properly in labour, then we would offer an internal examination to see where they're at. So she'd had 24 hours of that, and then she'd had another 24 hours of another one. And in that 48 hours, nothing happened. And at that point, she was offered a rest day. I think, I'm trying to remember if we moved on to the 6-hourly prostans at that point. Anyway, at some point she was offered a rest day and she said, well, I'd like to go home. And they said, okay, well, you can go home and come back and then we'd start again. And she said, well, no, actually, I think I'm done. I think this is as far as I want. I was really unsure about this anyway. And I feel like my body is not ready to labour and I want to listen to that. And the consultant that had come in to talk to her about this was really unhappy with this idea. And she said, because actually I think we must have talked about it before she came in. Oh, no, maybe, no, this might have been the first time it came up for me actually, where the woman herself said, can I stop this process now and go home? And I said, because I always do, what you do is totally up to you. The hospital is not a prison. Of course you can, but never having been in this situation before. And the consultant said, well, no, you can't. You know, that just, you know, you can't because you're here for a reason. You accepted induction for a reason. But for her, she'd been slightly convinced that maybe she should get the labour, you know, started off. But that had now been outweighed by the fact that her body was going, no. So for her, the situation was different. For the doctor, the situation wasn't, because the reason induction was offered was because she was carrying twins. And that is one of the reasons induction is offered. The reason she was accepting induction for her was not really about that. So at that point, I then looked up to see if there was any guideline that allowed for opting out. And I found that in the Oxford NHS Trust, their patient leaflet, their patient induction leaflet says, at any point you can go home. However, the safest time to opt out and go home is before having your waters broken, which is where we were at the time. And actually, the consultant said, well, you know, I definitely wouldn't advise this. It's never happened before. I went out of the room and we had a supervisor of midwives in the room also for that conversation. And after the doctor left, she said, oh, it has happened before. Women have gone. So the fact that it's not talked about doesn't mean that it doesn't happen. And certainly since then, you know, I found it really useful finding it actually in an NHS patient leaflet on induction. So since then, I've been very upfront with women about this is something you can do. But yeah, from a medical point of view, if induction has been offered to someone, then they feel like you are having an induction for a good reason. Why are you backing out? But yeah, a birthing person's decision-making processes are so much more nuanced than that. Their pros and cons are so much more complex and individualized than that doctor's is for their population of birthing people. So yeah, so we've got to, you can have 2 ProPessers, but it depends a bit on the trust. So sometimes you get 2 lots of 24 hours. Some of them, the trust and the doctors, actually, the different doctors you're under might have different plan on how they do it. But the next step after 1 or 2 of those can be 6-hourly Prostin tablets, which again get sited up near your cervix and left to dissolve, and they're stronger than the ProPess. And again, they're trying to convince your cervix to soften and efface and dilate. And the target of this, and this is again something that I'm not sure everybody understands before they get there, the whole reason they're doing this is to try and make your cervix open enough to manually break your waters. That is the goal. So when you're offered your initial examination, when you come in having agreed to induction, if in that initial examination someone goes, oh, actually, I could break your waters now, that whole first bit gets skipped. You don't need the ProPess, you don't need the Prostin, because what we were trying to do with that anyway was open the cervix enough to break your waters. So if you can cut to the chase and do that straight away, then that can be done. But it doesn't have to be. And again, this is something where people can negotiate. So once your waters are broken, most guidelines want you to be laboring within 24 hours. And that is because there is a risk attached to the baby being unsealed from the world, been nicely sealed off potentially by the bag of waters. Once we've broken them, then there is potentially a pathway for external bacteria to go in. Now, as you'll know, Mel, because I know we all say this a lot, the risk is not great. It only goes up by 0.5%. It goes up from 0.5% to 1%. So you're still very likely not going to get ill from your waters having been broken and the baby not being sealed up from the world. The chances are really small, but they have increased. So again, when women are offered induction because their waters have gone, and it should be very clearly 2 options they can consider. They can accept induction in 24 hours if they're not in active labour by then, which is one of the plans from the national guideline. Or they can say, no, thank you, in which case the advice is, actually, as soon as their waters go, the advice is to do 4-hourly temperature taking, because mother's temperature can be a sign of an infection. And then just have extra monitoring. So it's absolutely fine to say, I know my waters have gone, but I don't want to have induction within 24 hours. If I'm not in active labour, I just like to await events. But that is the reason that if you're not sure you want to continue with the induction process, it's probably a really good idea to come to that final decision when you're at the stage of having your waters broken. Because if you think you're not going to keep going, then adding in that extra risk factor and an extra way for health professionals to, I guess, use pressure and you talk about the risk of infection to add into that discussion. If you think you're probably not going to go ahead with the induction, then you probably want to avoid going beyond that step. I should say as well that if people have had ProPess and Prostin and nothing's been happening, then negotiating to go home would probably involve waiting for a couple of hours with the idea of those hormones leaving your system, and having, you know, a trace of the fetal heartbeat and having your obs done and just looking like everything is back to the status quo before you go home. And that makes sense because those hormones have been introduced artificially and to affect your body. And if you're not going to continue with being in hospital care, then you want to know that your body's settled down from whatever might be going on with that.
So what if, so if the cervix hasn't changed after those 24-hour things, and how many of the 6-hourly tablets would they offer?
3 usually.
3.
Usually 3. So it's usually another, it sort of adds up to another night in the hospital of waiting around.
It's like 3 days.
Yeah. This is why things can go on and on, because there's a lot of waiting around, and people often turn up expecting to be in labor, a few hours later, and that can happen, but it's much less likely.
Yeah. And so if there's been no change to the cervix, or only very slight, but there's still no opportunity to artificially rupture the membranes after those, like, give or take 72 hours, I'm not aware of anybody who's been offered to then go home. So if they, or who's been aware that they could then say, no, I'd like to stop this process and to go home, what is the general kind of next steps if they stay in the hospital? Can you put up
at that point,
drip, or would that then just become a surgical thing?
This is something that again is not very clear. Until the waters are broken, the policy is there is no point starting the drip, because it's not really effective when the waters haven't been broken. Do you know what? I didn't even know the physiology of this, but I've seen it where everyone was convinced that someone's waters had been effectively broken, and then they went way to the top of the scale of what we, as far as we're allowed to go in terms of the level of the volume of the hormone infusion. Nothing happened. And someone was like, I think they got another doctor to come in and go, and they found that it was really hard to find where they were, but the waters were still intact. So you can't, unless the waters are gone, you can't move on to the hormone drip. So if you've had 2 days of prostin, 2 days of Propest, 3 lots of prostin, and nothing's happened, you're usually offered a rest day at that point. They'll usually assume that you were going to stay in the hospital in that day. So it'll be like, here we are, we're assessing you on Wednesday morning, have a 24 hours of hanging out, and we'll be back again with the doctor's round on Thursday morning and start the whole process again. And that can literally be back to 24 hours of Propest. And one of the things about the breaking the waters thing, I was looking after someone the other day where I was supported to, because she'd actually been told in the community, oh, I could pretty much break your waters now, so when you're going for induction, you should be fine. Now, on examination of her, she was about 1 centimeter dilated, so people very good at breaking waters could have done that, but the cervix was the full tubal length. And I was supported to just go, the fact that you can break her waters now doesn't mean you should. Like, if her body had been doing any sort of preparing of its own accord, you wouldn't have this 3 centimeter length solid cervix. So just start from the beginning. So she had 24 hours of Propest. I'm trying to think, this was her second baby. She had 24 hours of Propest. And then, it wasn't 24 hours. You know what? We put it in at like 10 in the morning, and she had her baby at 2 a.m. that night. So her body did, with that encouragement, do its own thing. So we didn't add that risk factor in by breaking the waters, even though technically you could go, well, that's further down the induction stage, let's just do that. Actually, this was much better for her. So that's, again, there's a bit of room for negotiation, that if people understand, especially if someone is hoping to labor with minimal interventions and risks, even if they are accepting some level of induction, then actually asking to get the full whack of the hormones before the rupture of membranes is worth doing. So where was I? So rest day, and then start the process again. Now, it's not that many people that happens for, and usually at that point, they would offer you a section as your other alternative. They'd just be like, do you know what? This might not going to happen this way, because we have thrown all the hormones we've got at your body, and it doesn't even want to open the cervix enough to let us break the waters. So we may be on a hiding to nowhere here. So definitely part of the guideline is to offer a section at that point, or offer a rest day to start again, which, you can imagine, can't you, that if someone's body was planning to birth at like 42 weeks and this process starts at 41 weeks, they might well go into labor at 42 weeks, and it'll look like it's because of like 2 whole sets of this stuff. And actually that was when they were going to birth anyway. because it can, yeah, you can end up passing a lot more time. And this is why the guideline says offer induction of labor from 41 to 42 weeks. But because if the risks are considered to rise at 42 weeks, then actually, you know, because sometimes people do say, well, if I'm, as I said before, really, if I'm, you know, in the normal term window until 42 weeks, why are they wanting to reduce me at 41? And the reason is because nothing might happen for days. So yeah, we'll come on to the risk thing in a minute. But yeah, so that's the process in terms of leading up to enough dilatation to break the waters. And that's where you go on to the next stage. So once waters can be broken, and that can be, I don't know, like sometimes you hear doctors talking about, oh, that was a really heroic one, meaning themselves, meaning they had to work really hard to get their hand in and get right around to that cervix and manage to get the amni hook into just about, you know, it's like, again, you hear that and you think, I don't think this is going to turn into labor, because that's not a body that's ready to labor. But ideally, once the waters are broken, the pressure of the baby's head is now much more firmly on the cervix. So the cervix is more stimulated. And again, in a lot of trusts, they'll say, wait 2 hours and see what happens. Now, I begin to think that's a bit meaningless, because if at 2 hours, unless someone is having 3 to 4 strong surges every 10 minutes in like the actual definition of labor in terms of surges, everyone would be expecting to put up the drip anyway. So quite often I'll look after people who go, oh, I'm contracting, like I won't have to go on the next stage, I'm contracting. And they're contracting 1 in 10. And everyone in the hospital will ignore that. They'll just be like, oh, that's nice. You know, you'll think you're going into labor, but it's not good enough for the induction process to stop. So that 2 hours, if someone isn't really already laboring, is probably not going to mean anything. But I kind of always support people to buy all the time they can. So I'll always throw those 2 hours in, and I'll say, well, ask for more if you want. You can ask for 4, you can ask for 6, you know. So yeah, there's a stretch of time which is negotiable. But obviously, one of the hospital arguments is, well, we did just break your waters and the risk of infection has now gone up, so we don't want to just wait around. But again, somebody hoping to birth naturally as opposed to the hospital and their population view of statistics, you know, they're on different pages as to what their priorities are. So then we, at this point, before someone's waters are broken, we would want to put a cannula in their arm. And again, like people tend to say, oh, why now? Like, you know, nothing's happening. But again, it can be because as soon as you break the waters, you have added in some risk factors. So if you're one of the really unlucky people whose baby's cord came down ahead of its head and suddenly it had a heartbeat dip because of the lack of oxygen due to the compressed cord, you'd want a cannula in your arm because you'd be going to theatre. Now, it's really annoying. It doesn't make you feel like a kind of, you know, mobile, comfortable person because you've suddenly got a plastic thing in your arm. So I also am really happy for if people say, I don't want that in now. Do I have to have that in now? If I'm going to have 2 to 4 hours moving around and waiting to see if labor will come on, can we leave that till later? And it's not the hospital routine. It's not what the guideline says. But yeah, of course you can. You don't have to accept anything you don't want to accept. But obviously, if you're then going to accept, at the point that you are going to accept the hormone drip, then that is the way it's going to go into your body. So at that point, you do need a cannula. And we start it at a dose of 3 mils per half hour. That's the drug goes into an infusion of normal saline. So it's 3 mils of the infusion. It's not 3 mils of artificial oxytocin. It's 3 mils of an infusion with a small amount of artificial oxytocin in. And we double that rate. I think there's a point where it's not quite doubling, but mostly we double it every half hour because we're aiming for 3 to 4 strong surges lasting a minute or longer every 10 minutes. And in fact, the guideline is comfortable with 5 in 10, which someone's body would never actually do. Well, I've never seen it do it, but that's fine by the guideline. More than that, and we consider we've overstimulated the uterus, and we would stop the hormone drip if we thought that was happening, because we know that is too much for mother and baby. Hang on, I'm just going to check what that phone message is. Oh, that's from you. I'm just aware of time. Like, I'm not the most succinct person in the world, Mel. Are we all right to keep going? Okay. So when that drip starts, people usually really feel it quite quickly. So there's not the slow lead-in that natural labor usually gives people, not always, usually, because we are creating contractions artificially, and we're doing it according to a formula. And we're not even doing it in the same way that the body does it. So something that I find quite interesting is that we are doubling the dose, we are doubling the amount of artificial oxytocin the body is exposed to. That's not what the uterus does. It's not what the body does. The body increases the amount of receptors that are taking in the body's natural oxytocin. So we can create too many contractions in a way the body can't, because we're literally increasing the amount of hormone that's going in. So the risks associated with induction are obviously, creating too many contractions for the body to cope with, for the baby to cope with.
I think that's really fascinating what you're saying about how actually, so are you saying the way labor progresses physiologically without unmedicated is that the receptors, there are more receptors, or
the receptors increase? Yeah. And I have to go, every time I have to explain this to someone in detail, I have to go back and reread it again myself, because because of like this sort of complex terminology to do with it. But it's basically like, this is one of the reasons why induced labor is different from natural labor, because it's a different process. We can't make the body grow more receptors, so we can't do it that way. So we have to do it in a different way.
Yeah, and so that's really interesting. I thought that I had my first labor augmented. Anyway, that's another story. But so I had the syntocinon drip, and it really annoys me because I hear healthcare professionals saying we're going to use oxytocin, and we're going to do an oxytocin drip, and I'm like, it's not oxytocin. So don't talk about it as oxytocin.
No, it has different properties.
My understanding was that because it was a synthetic form of oxytocin, that I understood it that when our body produces oxytocin naturally, it also produces
endorphins.
Pardon?
Endorphins, are you thinking?
Endorphins, yeah, which is our natural painkillers. But if synthetic oxytocin is being introduced, then we're not producing oxytocin, and then our endorphins are not released either. Is that how?
Yeah.
I mean, is that why it feels so much more intense, as well as also not having more more.
And to some extent, your body will produce some endorphins, because that is what our body does in response to pain. So if we're finding an induced labor painful, there will be some endorphins produced. But it's not like the package deal that's kind of very subtly works together the way natural labor starting off does. That's usually a kind of slow lead-in process where your body has a lot of time to build up those endorphins. And like that is not the chance we give the body in terms of the way we do the drip. So this is why induced labor's not for everybody, but for most people, they're experienced as more painful, which then has a whole cascade of intervention scenario there, because if you're feeling more uncomfortable, you're going to ask for more pain relief earlier, you're going to ask for stronger pain relief, you're more likely to end up with an epidural. An epidural is more likely to immobilize you. A less mobile birth can be a more difficult birth for the baby to maneuver its way through the pelvis. That can mean that you start to lag behind the hospital time limits. So the hospital's saying, well, this is taking too long to happen, therefore we need to do more interventions, which can obviously lead to a section. It can lead to an instrumental birth or a ventouse birth. So yeah, It depends. It does depend. Like I have seen some labours, obviously I've seen quite a few induced labours where people don't get as far as the hormone drip, their body really does join in. And then, you know, depending on the reason they accepted induction, they might well end up having a great pool birth. You know, if it's a, if they're accepting it because of length of pregnancy, then it'd be hard for anyone to argue why they couldn't have a pool birth. I think if they're over 42 weeks, then they'll have a lot of medical people going, oh, well, you know, that's not a normal length of pregnancy. So you should be having continuous monitoring, which in real terms, I've never seen successfully done in the pool, even though it's supposed to be able to be, not for any length of time. I've seen lots of women being told they have to get out because we can't use the remote control fetal monitoring machine successfully for a consistent trace because the water keeps floating off the connections. So yeah, they have that little taste of the pool and they're told, oh no, we really need, and you know, again, a woman would have every right to go, actually, I'm staying in the pool and I'm ditching the monitoring. But there's a lot of pressure, not evidence-based, because continuous fetal monitoring doesn't improve outcomes according to the Cochrane review, as I'm sure you know. It'll be interesting to see when this kind of physiological CTD package comes in many trusts, which it's starting to. Edward Chandraharan's work on trying to actually get some decent outcomes out of fetal monitoring machines. he does get better outcomes. I kind of think we're working with a flawed machine in the first place, so I'm not wholly convinced about this. But yeah, people tend to feel like once they're on one of those continuous monitoring machines and they've been hearing that heartbeat, then they, and often usually the staff, tend to be very unhappy about the idea of going back to intermittent monitoring. So even if someone was low risk in every way except the length of their pregnancy, yeah, there would be an argument that they shouldn't be in the pool because they need continuous monitoring. But, you know, for someone who, I guess, I'm just trying to think of one of the few reasons that induction's offered that might mean you could get away with the pool birth. Yeah, I think it depends on how broad-minded and relaxed the staff are, because I think for most staff, they'd feel much happier if you're accepting induction, that it must be for some reason that there's a problem or there's an increased risk, and therefore you should have continuous monitoring. But it would depend on what the guideline said about people's particular circumstances as to whether that really was advised, and they can always say no. They can always say no because there just isn't good evidence for that being a better way than intermittent listening in, which can very easily be done in the pool. So yeah, so once you get to the drip, if you get to a point where you're getting 3 to 4 strong surges lasting a minute or longer in 10 minutes, then the person looking after you should not need to turn the drip up anymore. It should stop at that point. If they think that there's a problem with the fetal heart, which sometimes can be unhappy with the induction process, they would turn the drip off and get everything reassessed. If they thought that they'd overstimulated your uterus and you were getting 6 contractions in 10 or something like that, they'd turn it off and reassess. And that might well end up with the doctor coming in, checking everything out, and then advising to start again with the drip, but at a lower dose. The guideline goes up to an infusion of 96 mils an hour, having started at 3. So someone may get all the way to there. After a certain point, people would start saying, are we sure those waters were broken? Could we have possibly got the hindwaters? Did we definitely check that there was definitely no waters in the way? Because, as I said, that can make that drip less effective. And the dosage of the drip doesn't necessarily affect what you're feeling. I've seen people go all the way up to 96 and not really seem to feel any different from when it was at 6 or 9. Yeah, but obviously the body is experiencing an increased amount of the artificial hormone. We know that artificial oxytocin suppresses natural oxytocin. Therefore, some of the risks of induction can include the things that won't work so well if you don't have your own natural oxytocin kicking in. So that can be, that can even be bonding with your baby. If you're not flooded with lots of lovely natural oxytocin when your baby's born, it can affect how you feel at that time. I mean, not everybody has that total overwhelming, bonding thing happen at that moment anyway. Sometimes that's a bit further down the line, or it's a bit more low key, but we know that induction can affect that process. It can affect breastfeeding and the establishment of breastfeeding. Sometimes that can be to do with the associated things to do with induction. So if you've had a lot of pain relief drugs, then you might have a baby that's more sleepy, and just not having all its breastfeeding instincts kicking in, and that alertness to learn in that kind of early optimal couple of hours. The drip stays running until you've had your baby, until you've birthed your placenta, and usually for half an hour afterwards. And that again is because, having suppressed some of your own natural oxytocin, it's reasonable to not leave your body to its own devices to do anything that involves oxytocin. So pushing the baby out obviously does, the birthing the placenta does, because that happens because the contractions are getting the uterus to contract down smaller, the placenta can't contract down smaller, so it needs to come out. And your body needs to go on contracting that uterus down so that you have an appropriate amount of blood loss rather than an unsafe amount of blood loss. So if we turn off the drip anytime before any of that's happened, we might be leaving you with not enough of your own oxytocin to do those jobs. And that's why I think we turn it down by half as soon as the placenta's out, and then half an hour later we turn it off. There's the associated risks of more birth interventions, potentially because of the immobility, because you're not necessarily moving in as comfortable a way as you might be if you had a lot of endorphins on your side. Also because you're attached to a bunch of stuff by this stage. So even if intellectually, you could get up and walk around by, wheeling your drip machine with you, and hopefully having the wireless belts around you, although the hospitals are still using many where you're literally attached to stuff, then you've got another machine to move around with you. But also, quite often, it's quite hard to keep those belts monitoring the fetal heart. So there might only, whereas in theory you could move around even hanging onto both those machines, actually it might be that there's only one position that your midwife can manage to keep that fetal monitor picking up the heartbeat consistently. So she might be saying on the one hand, oh, do try and move around here, you could sit on the birth ball. In an actual fact, she might be going, we've lost the trace again. Look, I'm really sorry, I can't seem to pick it up here. Would you just go back and lay back on the bed again? Because that semi-recumbent position is usually the easiest place to monitor the baby. So yeah, there's just so many knock-on effects of it all, which might not happen for someone, but we know that they're all more likely. I've just noticed my computer battery is going down. I'm just going to plug it in. Hang on a minute.
We're on 2:15. I don't know if that, if you need to go, Sharyn.
So what this all adds up to really is, I think people really need to know the stats on why they've been advised to have an induction, and then they need to think about what those stats mean to them. Depending on where you look now, certainly for long pregnancies, you get really very low stats on unexplained stillbirths. We can't say there's stillbirths to do with long pregnancy because we don't know. We know that in some longer pregnancies, the babies don't make it, and we don't know why. It's quite hard to get stats on that because they are so small. So we know in some cases that there are babies that would never have been okay, whatever gestation they were born at. And we know in some cases, babies that have got issues going on seem to not trigger labor. So it's not that the long pregnancy meant that they weren't all right. They had a long pregnancy because they weren't all right already, and they wouldn't have been all right at whatever point they came out. And it sort of depends where you look. So at the moment, I'm just I mean, you'll be able to look this up, Mel. But I'm just looking at, yeah, it's a bit of a weird one, because we used to say that the risk of stillbirth went up at 41 and at 42 weeks. Now, actually, the UK figures are that it goes down, which is probably because of how many inductions we're doing. So even if, as I'm just trying to think of a way to explain it, a consultant once said to me, if we induced 1 in 5 women based on their postcodes, we would avoid some stillbirths. That doesn't necessarily mean that we're inducing the right women. It just means we're inducing so many women that we're going to avoid some stillbirths. So it's quite hard for me personally to tell, I guess, what the meaningful risk for an individual would be. Because actually, we can't even anymore say the risk of stillbirth goes up after a certain point, because based on births and population in the UK, it actually goes down. But that is almost certainly because so many babies are being born before they get to that point. It's not because necessarily we're picking the right people in a really precise and scientific way. Sometimes there's really clear risks. Like we know that mums who smoke have got a much bigger risk of stillbirth. And so I think probably there are times when babies are better coming out of an environment where the risks are quite high for them. But I don't think we're inducing proportionately. I mean, it's something like 50% of births in the UK now don't start off naturally. Now that's suggesting that half the UK's women aren't healthy enough, or aren't having healthy enough babies to just go through the normal birth process and come when they're ready. And I don't believe that. Yeah, let me find this. So I can send, I think for the stats, you're just as well to look at, Rachel Reed's Why Induction Matters or something. She's pretty much got them all in there. Oh, the only thing that there's a typo in there that it's worth knowing about. Do you remember the study that I said women who have previously birthed a well baby post-term, the evidence is that they'll be absolutely fine to do so again, and they don't have any increased risk of stillbirth after 42 weeks. She's actually erroneously put it in as post-dates, so it sounded like anyone, but I went and looked at the study because I thought, hang on, that's not right. And it was post-term. So it looks as if anyone who's birthed after 40 weeks safely doesn't have any increased stillbirth risk in future, but it's actually after 42 weeks.
Okay.
But yeah, so if the couple of things that I've looked at here, babies born after 37 weeks gestation in the UK are extremely likely to be born alive and well. This is irrespective of whether post-dated pregnancies are induced or whether labour induced spontaneously. Now that's, I can't say this, Gulmazoglu et al. 2009. So that's extremely likely to be born alive and well whatever we do. That's just generally babies that get past 37 weeks. Then Guardiosi et al. 2013, they found that after 41 completed weeks, there is a slight increase in mortality of babies up to 1 month of age.
Okay.
Cochrane Review says births after 42 weeks gestation may slightly increase risks for babies, including a greater risk of death before or shortly after birth. However, induction of labour may also have risks for mother and babies, especially if women are not ready to labour. No tests can predict if babies will be better to stay inside their mother or if labour should be induced to make the birth happen sooner. 90% of women who choose to wait will birth before 42 weeks. Only 1% will remain pregnant beyond 43 weeks. I've looked after 2 of them. There is no clear cutoff point at which continuing a pregnancy becomes dangerous, and the risk of stillbirth still remains below 1%. So it's one of those scenarios where even though some studies suggest the risk goes up after a certain point, it only goes up from less than 1% to still less than 1%. Rosenstein et al., that was 2012, found the perinatal death rate to be approximately 0.1% at 40 to 41 weeks, 0.3% at 42 weeks, and 0.5% after 43 weeks. The most recent Embrace report 2018 found the actual UK stillbirth rate during 2014 to 2016 to be 0.15% between 37 to 41 plus 6 and 0.1% at 42 weeks onward. So that's that decline. And the Cochrane review found that induction of labour before 42 weeks reduced the rate of stillbirth from 0.3% to 0.03%. So there you go, like nobody's getting the same figures. And this is why it's a bit hard to tell, you know, we used to say it went slightly up, now it looks like the reality it goes slightly down, but the figures are so small, it's really hard to get meaningful, you know, representation of what someone's individual risk is at that point.
And I guess it's also really useful to kind of think about, well, what are they looking at births that haven't been induced, where those babies are stillborn or not, or is it just across the board, whether the labor is induced or not?
Yeah.
So,
and yeah, different studies will be doing different things, and obviously, like it isn't very easy to make sweeping statements about a whole population and still be accurate. So yeah, the difference between someone who's, because, you know, one of the things they take into account is age, and yet there's a big difference between someone who's 45 and really fit and healthy with no associated health risks and someone who's 28 who's a heavy smoker. You know, then saying, oh, because of your age this is likely, between those two, but it's, you know, it's probably the other way around. So yeah, it's why they say no actual test can predict whether your baby is better off out than in at any point beyond 37 weeks.
It's 2:20. That is amazing that we've fitted all of that information into an hour or just over an hour. For me, what I've taken away from all of this is really that it is the individual's choice.
Yeah, we always come back to that. Yep.
They can stop the process at any point. We know that they're probably going to come up against quite a lot of resistance to stopping the process, because their reason for starting the process is different to the medical professional's reason. So yeah. Oh my gosh, just thinking like three or 4 days, nothing's happened, start again. I'm like, oh my word, that's just, who wants to hang out in the ward for a week?
I forgot to throw in as well that in some places now they're using induction by catheter balloon. Have you heard of that?
Yeah, in our trust, the trust that I'm geographically closest to, they only offer balloon induction for people who've had a previous cesarean birth.
Yeah. I mean, I'd heard that in some areas, I think this might have been rather experimental, women were supported to go home while their balloon catheter was in place, because you can't overstimulate a cervix, as far as we know, with a balloon catheter. It doesn't involve a drug, so that you can't have some sort of drug reaction away from the hospital. And you'll know if it's working because it'll fall out, because your cervix will have opened up enough to fall out. And I got quite excited by that, because I thought, well, those women who really do want to accept induction, that could make the process much less, you know, much more mobile, much more relaxed, much less stressful. They can be with their children at home. And yet I'm pretty sure the trust that I heard that was doing that has stopped doing that. And I don't know why that is. So I can see the argument for having balloon catheter as a way of not potentially putting extra pressure on a previous section scar. Because yeah, it's not likely to create any overstimulation of the uterus, because it's not a drug that does that. It's a manual actual thing that's just creating pressure, and not on the uterus, obviously on the cervix. But yeah, I thought, wow, this could be a more woman-friendly way to start the induction process. And I do think there are some places in the world where that is what they're doing, but I haven't looked into it very recently, and it hasn't seemed to be used for that benefit here. It has been it seemed to be very much focused on for VBAC women, but they still get stuck in the hospital. Yeah, it's something I should look into, really, because it might be, you know, if it's done in other parts of the world, it might be something women could negotiate for.
Definitely.
Well, and especially, you know, especially in the situation where their trust really wants them to have an induction. I mean, that's one thing that, you know, if you're in a situation where you are getting a lot of pressure, which isn't appropriate, but if you are, you can sometimes use it to your benefit by negotiating stuff that wouldn't otherwise be approved of. So if someone was like, well, I don't want an induction if it involves me sitting around the hospital, I'm just not going to agree to that. But if I can have a balloon catheter and go home until it falls out, I'll give that my consideration. And that suddenly might be on the table then, in a way that it wouldn't normally be.
Yeah.
But I don't know. I have yet to see if anyone tries that successfully. But certainly that thing of like getting some stuff on the table that wouldn't normally be there because your trust wants you to do something, like that is always worth giving it a whirl.
Yeah, I've supported a few families where they haven't wanted a medical induction, but they've said, like, you know, it's been their first full-term pregnancy, and so they've said, you know, can we have a balloon induction instead? And the answer has been no, which is just like, and what is the reason for your saying no? You know, so
yeah, I think it's one of those things that won't be done by anyone until someone does it. And then, you know, once you've, because quite often trusts don't even know what the next door trusts are doing. I mean, there's a bit less of that now that they're trying to standardize using the LMS areas. But yeah, like quite often you'll have people going, oh no, well, no, that wouldn't happen. And as independent midwives working in lots of trust areas, we often go, well, actually, no, they're doing it. They've been doing it for years. You know, the one down the road, it's totally possible. Would you like me to put you on to one of the doctors who does that, and you can have a chat and maybe feel more confident about it? Yes.
Yeah.
Well,
okay. Well, I need to say goodbye, but thank you so much for all of this information. I'm going to just stop recording because I don't need to